Hello everyone, and welcome to this episode of the 𝐵𝑒𝑡𝑒coccus video series, where we delve into high-yield topics that frequently appear on the NBME and USMLE exams. In this session, we're focusing on Crohn's disease and other topics like Lynch syndrome and more. Let's start explore a series of clinical scenarios that illustrate the diverse manifestations of Crohn's disease. Our first Crohn's case involves a 28-year-old man presenting with vague abdominal pain, low-grade fever, and persistent diarrhea. Despite treatment with antibiotics, his symptoms do not improve, and he eventually develops a draining skin lesion in the right lower abdomen. This scenario is indicative of Crohn's disease complicated by an enterocutaneous fistula, a tract that forms between the bowel and the skin, allowing bowel contents to drain externally. Crohn's disease is characterized by transmural inflammation, which affects the entire thickness of the bowel wall. This deep inflammation can lead to the formation of fistulas, strictures, and abscesses. In this case, the development of an enterocutaneous fistula is a direct consequence of the chronic, penetrating nature of the inflammation. Management of such complications often requires surgical intervention in addition to medical therapy to control the underlying inflammation. Recognize the complications of transmural inflammation in Crohn's disease, particularly the formation of fistulas, which are frequently tested on the Step 1 exam. Okay now, in this case, a 45-year-old man with Crohn's disease has not responded adequately to treatment with mesalamine and has experienced disease flares requiring corticosteroids. His physician decides to escalate his treatment by introducing infliximab, a TNF-alpha inhibitor known for its effectiveness in inducing and maintaining remission in moderate to severe Crohn's disease. However, before initiating infliximab, it is crucial to screen the patient for latent tuberculosis. TNF-alpha plays a key role in the immune response against TB, particularly in containing latent infections. Inhibiting TNF-alpha with infliximab can lead to the reactivation of latent TB, a potentially life-threatening complication. The recommended screening involves a tuberculin skin test or an interferon gamma release assay. If latent TB is identified, the patient must undergo prophylactic treatment, typically with isoniazid for 9 months before starting infliximab therapy. This precaution is essential to reduce the risk of TB reactivation during immunosuppressive treatment. This case highlights the critical importance of pre-treatment evaluation when escalating therapy for Crohn's disease, emphasizing the need for TB screening to ensure patient safety and effective management. Next, consider a 32-year-old man who presents with abdominal pain, intermittent diarrhea, and heme-positive stools. A colonoscopy reveals patchy areas of inflammation, and a biopsy of the affected mucosa shows non-casseting granulomas. This finding is a hallmark of Crohn's disease. Non-casseting granulomas are composed of epithelioid macrophages surrounded by a rim of lymphocytes. These granulomas form in response to an unregulated immune reaction, likely triggered by gut flora or self-antigens. Unlike ulcerative colitis, which only involves superficial layers of the bowel wall, Crohn's disease affects all layers, leading to these characteristic granulomas. Identifying non-casseting granulomas on biopsy is crucial for diagnosing Crohn's disease and differentiating it from ulcerative colitis. Our third case involves a 24-year-old woman with a history of recurrent bloody diarrhea and right-sided abdominal pain. Despite medical therapy, her symptoms persist, and she eventually undergoes a colectomy. The resected bowel shows a thickened intestinal wall, which is a key feature of Crohn's disease. This thickening is due to transmural inflammation that affects all layers of the bowel, leading to fibrosis, muscular hypertrophy, and eventually stricture formation. On gross examination, the bowel may show a cobblestone appearance, skip lesions, and creeping fat, all of which are pathognomonic for Crohn's disease. These findings reflect the chronicity and severity of inflammation in Crohn's disease, which can lead to bowel obstruction and require surgical management. So it's important to recognize the gross pathological features of Crohn's disease, such as bowel wall thickening and cobblestoning, which are essential for distinguishing it from other types of inflammatory bowel diseases. In another case, a 33-year-old man with Crohn's disease presents with severe left-sided flank pain and subsequently passes a kidney stone. The formation of calcium oxalate kidney stones is a known complication of Crohn's disease, particularly when the terminal ileum is involved. The terminal ileum is responsible for the reabsorption of bile acids. When it is inflamed, bile acids are lost in the feces, leading to fat malabsorption. Free fatty acids then bind to calcium in the gut, leaving oxalate free to be absorbed in greater quantities. This increase in absorbed oxalate leads to hyperoxaluria and promotes the formation of calcium oxalate kidney stones. This case highlights the systemic complications of Crohn's disease beyond the gastrointestinal tract, emphasizing the importance of comprehensive management to prevent such occurrences. So be sure to understand the mechanism of oxalate kidney stone formation in Crohn's disease and its relevance to systemic complications. Consider a 25-year-old man with a known history of Crohn's disease who presents with worsening abdominal pain, distension, and vomiting over several days. Imaging reveals a small bowel obstruction, and laparotomy confirms the presence of a mass composed of inflamed small bowel, adherent mesentery, and enlarged lymph nodes. The underlying cause is a fibrotic stricture resulting from chronic transmural inflammation, a hallmark of Crohn's disease. Strictures in Crohn's disease develop due to a combination of edema, fibrosis, and hypertrophy of the muscularis mucosae, all of which contribute to narrowing the intestinal lumen and obstructing the passage of bowel contents. This case underscores the progressive nature of Crohn's disease and the importance of monitoring for complications that may require surgical intervention. Finally, let's discuss a 45-year-old woman with Crohn's disease who presents with recurrent right upper quadrant pain, especially after fatty meals. An ultrasound reveals multiple gallstones, a complication often seen in Crohn's disease, particularly when the terminal ileum is involved. The inflammation of terminal ileum leads to decreased reabsorption of bile acids, which are essential for solubilizing cholesterol in bile. As a result, bile becomes supersaturated with cholesterol, promoting the formation of cholesterol gallstones. This case highlights the intersection between gastrointestinal pathology and hepatobiliary complications, an important area to understand for the step 1. Okay, here is another high-yield topic which are frequently tested on the Step 1 exam, Lynch syndrome, also known as hereditary non-polyposis colorectal cancer. A 38-year-old man who presents with bloody stools, significant weight loss, and anemia. His medical history is unremarkable, but he reports a family history of colon cancer, with his father having died of colon cancer at the age of 40. His sister has been diagnosed with endometrial cancer. On physical examination, he has mild right-sided abdominal tenderness, and stool testing is positive for occult blood. Colonoscopy reveals a right-sided ulcerative mass in the colon, and biopsy confirms the presence of adenocarcinoma. Given the patient's young age and family history, Lynch syndrome is highly suspected. Lynch syndrome is an autosomal dominant disorder characterized by mutations in DNA mismatch repair genes such as MSH2, MLH1, MSH6, and PMS2. These genes are responsible for the repair of errors that occur during DNA replication. A mutation in one of these genes results in a predisposition to cancer because of the accumulation of mutations in various genes, ultimately leading to malignancy. In this case, the mutation is most likely in the MSH2 gene, one of the key genes involved in Lynch syndrome. This genetic mutation predisposes individuals to colorectal cancer, typically presenting before the age of 50, and is also associated with other malignancies, including endometrial and ovarian cancers. Understanding the genetic basis of Lynch syndrome is crucial for recognizing and managing these patients, both in terms of early detection and preventive strategies. Clinically, Lynch syndrome accounts for about 3 to 5% of all colorectal cancers and is the most common hereditary colorectal cancer syndrome. The condition also increases the risk of other types of cancers, particularly in the endometrium and ovaries, making early detection and family screening vital. When you encounter a young patient with colorectal cancer and a significant family history of similar cancers, consider Lynch syndrome as a likely diagnosis. Genetic testing and counseling are essential for the patient and their relatives to assess cancer risk and guide surveillance strategies. We have here another frequently tested topic on step 1, a small bowel obstruction or SBO. Let's explore this case of a 65-year-old woman who presented to the emergency department with a 24-hour history of abdominal pain, nausea, and vomiting. The pain was described as coming in waves, a characteristic feature of colicky abdominal pain associated with SBO. Her medical history was significant for atrial fibrillation, non-ischemic cardiomyopathy, hypertension, and type 2 diabetes mellitus. She had also undergone an abdominal hysterectomy 15 years ago for endometrial hyperplasia. On examination, her abdomen was distended and tympanic, with active bowel sounds, which is indicative of early SBO. Abdominal x-rays revealed dilated loops of the small bowel with multiple air fluid levels, classic radiographic findings for SBO. This case highlights that a history of prior abdominal surgery, in this instance, a hysterectomy, is the most significant risk factor for SBO in high-income countries due to the development of adhesions. For the step 1, it's crucial to remember that the management of SBO typically begins with conservative measures such as bowel rest and nasogastric suction, but surgery becomes necessary if there is evidence of complications like fever or hemodynamic instability. Next, we discuss an 81-year-old woman who was brought to the emergency department with intermittent abdominal pain, nausea, and vomiting. Imaging revealed a complete small bowel obstruction, and surgery uncovered a cholesterol-rich mass obstructing the ileocecal valve. This is a classic presentation of gallstone ileus, another high-yield topic for step 1. Gallstone ileus occurs when a large gallstone erodes into the gastrointestinal tract through a cholecystoenteric fistula, ultimately causing mechanical obstruction at the ileum, the narrowest part of the intestine. Key imaging findings include pneumobilia, or air in the biliary tree, due to the retrograde passage of intestinal gas through the fistula. Recognizing these findings is crucial for both diagnosis and management, which typically involves surgical intervention to remove the obstruction. Our third case involves a 2-day-old male who presented with abdominal distension and bilious vomiting. Imaging and surgical findings revealed an inspissated green fecal mass obstructing the distal ileum, consistent with meconium ileus. This condition is highly specific for cystic fibrosis, making it another critical topic for step 1. Meconium ileus occurs due to the thick, sticky meconium caused by abnormal chloride and sodium transport in the intestines. In CF, the most common cause of mortality is recurrent pulmonary infections leading to respiratory failure. Beyond recognizing the clinical presentation, it's essential to understand the underlying genetic defect in CF and how it leads to multisystemic manifestations, including pancreatic insufficiency and malabsorption, all of which are important for the step 1 exam. Another case we discussed features a 68-year-old woman who presented with crampy abdominal pain and vomiting. Imaging showed air in the gallbladder and biliary tree, leading to a diagnosis of gallstone ileus. This case further emphasizes the importance of understanding the pathophysiology of gallstone ileus, where a gallstone erodes through the gallbladder into the GI tract, forming a fistula and ultimately causing obstruction in the small bowel. The patient's presentation of SBO symptoms along with pneumobilia on imaging should prompt immediate surgical intervention. Our fifth case involved a 64-year-old woman with worsening abdominal pain diagnosed with SBO due to an incarcerated inguinal hernia as revealed by a CT scan. Hernias, especially inguinal hernias, are a common cause of SBO and a frequently tested subject on step 1. An incarcerated hernia occurs when a portion of the intestine becomes trapped in the hernia sac, leading to obstruction and potentially strangulation if not promptly treated. This case serves as a reminder that the clinical examination supported by imaging is vital in diagnosing SBO and determining the need for surgical intervention. Next, superior mesenteric artery syndrome, which appeared many times in step 1 exam through recent past years. A 26-year-old woman with a history of anorexia nervosa who presented with severe postprandial abdominal pain and vomiting. Imaging revealed compression of the third portion of the duodenum by the superior mesenteric artery, leading to a diagnosis of superior mesenteric artery syndrome. This condition, although rare, is a high-yield topic due to its unique pathophysiology. SMA syndrome occurs in individuals with significant weight loss, which depletes the mesenteric fat pad that normally keeps the SMA from compressing the duodenum. The result is partial or complete obstruction of the duodenum, leading to symptoms similar to SBO. Initial management involves nutritional support, but severe cases may require surgical intervention. Understanding the causes, presentations, and management of small bowel obstruction is essential for mastering the step 1. Whether dealing with adhesions from prior surgery, gallstone ileus, or an incarcerated hernia, the ability to recognize the clinical signs and appropriate imaging findings will be invaluable. Okay, here is another very high-yield case that discussing a severe complication of long-term alcohol use, specifically the development of esophageal varices due to portal hypertension. Our patient is a 52-year-old man who presents to the emergency department with vomiting blood, which began about an hour before his arrival. He has a long history of alcohol abuse, consuming large amounts of alcohol for more than 20 years, which has led to multiple hospitalizations for ethanol intoxication. On examination, his temperature is 36.7, his blood pressure is 90/60, and his pulse is 106 per minute, indicating hypotension and compensatory tachycardia due to blood loss. He also has jaundice, scleral icterus, a palpable spleen, and moderate ascites, all of which are classic signs of cirrhosis. Endoscopy reveals bleeding esophageal varices, a dangerous consequence of portal hypertension. So, the question is, which vein is responsible for the chronic shunting of blood that led to the development of these varices? The correct answer is the left gastric vein. In cirrhosis, the liver undergoes progressive fibrosis, which leads to distortion of the hepatic architecture. This fibrosis creates increased resistance to blood flow through the liver's sinusoidal system, causing portal hypertension. As the pressure in the portal system builds, blood is forced to find alternate pathways, or portosystemic anastomoses, to bypass the liver. One of the most significant routes is through the left gastric vein, which drains blood from the lower part of the esophagus into the portal vein. When this pressure becomes too high, the left gastric vein dilates, leading to the formation of esophageal varices. These varices are fragile, thin-walled veins that are prone to rupture, causing significant upper gastrointestinal bleeding, as seen in this patient. In terms of management, stabilizing the patient is the first priority. Endoscopic variceal ligation or sclerotherapy may be performed to stop the bleeding. For long-term management, patients with cirrhosis and portal hypertension often undergo beta blocker therapy to reduce portal pressure. In severe cases, a transjugular intrahepatic portosystemic shunt may be placed. This procedure creates a channel between the portal vein and the hepatic vein, effectively reducing the pressure in the portal system and the risk of future variceal bleeds. To sum up, this patient's esophageal varices are the direct result of portal hypertension caused by chronic cirrhosis. The left gastric vein plays a key role in the development of these varices, and their rupture is a life-threatening complication that requires prompt intervention. Let's move on to another important case, this time involving rectal bleeding in a 42-year-old man. The patient comes in reporting that he has noticed blood dripping into the toilet after defecation for the past few days. He has a history of chronic constipation and often has to strain during bowel movements, but he denies any rectal or abdominal pain. On endoscopy, we observe bulging purplish-blue mucosal lesions above the dentate line, which are classic findings of internal hemorrhoids. The question asks, which venous system is involved in the development of these internal hemorrhoids? The correct answer is the inferior mesenteric vein tributaries. Let's break this down. Hemorrhoids are classified based on their location relative to the dentate line in the anal canal. Internal hemorrhoids originate above the dentate line and are composed of the superior rectal veins, which drain into the inferior mesenteric vein. This is part of the portal venous system. External hemorrhoids, on the other hand, originate below the dentate line and are drained by the inferior rectal veins, which communicate with the internal pudendal vein and ultimately drain into the internal iliac veins. In this patient, the chronic straining due to constipation has caused increased pressure in the rectal veins, leading to the distension of the anal arteriovenous plexus. The superior rectal vein, a tributary of the inferior mesenteric vein, plays a key role in this process. The treatment for internal hemorrhoids often involves rubber band ligation, which cuts off the blood supply to the hemorrhoid, causing it to shrink and eventually fall off. The patient may also benefit from dietary modifications, such as increasing fiber and fluid intake to ease bowel movements and reduce the need for straining. In summary, internal hemorrhoids arise from the superior rectal veins, which drain into the inferior mesenteric vein. Chronic constipation and straining exacerbate the condition, and treatment may involve rubber band ligation or other minimally invasive procedures. Next, we have a 15-year-old girl who presents with confusion and hematemesis. She has a history of depression and liver disease, and unfortunately, she deteriorates and dies during hospitalization. Autopsy reveals nodular cirrhosis, esophageal varices, and basal ganglia atrophy with copper deposition. The cause of this condition is an abnormality in biliary excretion of copper, consistent with Wilson disease. In Wilson disease, a mutation in the ATP7B gene impairs the biliary excretion of copper, leading to copper accumulation in the liver. When hepatocytes die, the excess copper spills into the bloodstream, depositing in tissues like the brain, particularly the basal ganglia, which explains the neurological symptoms seen in these patients. This case emphasizes the importance of early recognition and treatment of Wilson disease. Without appropriate management, patients can develop acute liver failure, cirrhosis, and neurological deterioration, all of which are potentially fatal. In our next case, we have a 55-year-old man who was admitted to the hospital with severe abdominal pain, nausea, and vomiting. His serum amylase and lipase levels were significantly elevated, confirming a diagnosis of acute pancreatitis, most likely due to his history of heavy alcohol use. During his hospitalization, his condition deteriorates rapidly, and he develops severe respiratory distress with bilateral crackles on lung examination. Despite receiving mechanical ventilation and 100% oxygen, his condition worsens, and he ultimately dies from progressive respiratory failure. The key question is, what was the most likely finding on autopsy? The correct answer is alveolar hyaline membranes. This patient's presentation is highly suggestive of acute respiratory distress syndrome, a serious complication of acute pancreatitis. In ARDS, the inflammatory cytokines and enzymes released during pancreatitis cause diffuse alveolar damage in the lungs. This results in increased capillary permeability, leading to the formation of protein-rich pulmonary edema and the development of hyaline membranes within the alveoli. These membranes are composed of fibrin, necrotic epithelial cells, and protein exudates, and they interfere with gas exchange, leading to severe hypoxemia. ARDS is characterized by progressive hypoxemia that is refractory to oxygen therapy, bilateral pulmonary infiltrates on chest X-ray decreased lung compliance due to the alveolar and interstitial edema, despite aggressive supportive care, including mechanical ventilation with positive end expiratory pressure. Patients with severe ARDS may experience multi-organ failure and succumb to the condition, as seen in this patient. To summarize, this patient's ARDS was triggered by acute pancreatitis, leading to the development of alveolar hyaline membranes and fatal respiratory failure. Understanding the link between pancreatitis and ARDS is crucial for managing such critically ill patients. Make sure you master all the cases and concepts we've discussed in this video and in previous ones. These are frequently tested in the exam. Keep reviewing, stay focused, and you'll be well prepared for your step 1. Thank you for joining this episode of the Metacoccus video series. Stay tuned for more high-yield discussions on topics that frequently appear in your NBME and USMLE exams.